third scenario where there is a third molar impaction that takes place, right, which is an open extraction method. So I'd like to move on to my panelists here and ask them, why would basic sciences be important for any of these? Wouldn't adequate clinical exposure in your first year to final year be able to help you with all of these situations? So Riyaz sir, here I'll ask you this question. Why are we expecting to have complications with any of this, and how is basic sciences going to rescue us from this?
If you are not going to be thorough about the IINB landmarks, intraoral as well as extraoral landmarks and the height of injection 100%, we are going to injure the adjacent nerves and vessels. So it will end up with much more complications compared to the routine extraction or the routine procedure itself.
What do you think can possibly go wrong with an inferior alveolar nerve block? They give it, I mean, most undergraduates here give it during every case. So what can potentially go wrong?
Yeah, you have to choose the needle first, the size of the needle and the height of the needle, the bevel facing, all those things. If not, we can injure the facial nerve at the end of the day. So, which I think much more compared to the extraction, that problem will be much more, patient cannot afford for.
So the point here being landmarks, again, anatomy being extremely important. You're looking at potentially damaging areas like the parotid gland, where the facial nerve is present. So again, it all boils down to your first year anatomy. Sir Karthik, sir, can you tell us something about what can possibly go wrong with a closed extraction?
Even before going into the topic, let us have a small brief about the history of surgery all over the world. So why is your basic sciences important is the question here, right? So until 1700s, the surgeons did not have a curriculum. They were called as the Company of Barber Surgeons, which was a company in England, after 200 years of physicians forming an association. Even after that, after 200 years, the physicians were called doctors and the surgeons were called Mr. And they were denied to be called as doctors because they did not have a curriculum. Only after forming the board of surgeons, only then they had a curriculum to be called as doctors. So to be very basic, if you have to be called as doctor, you should have a knowledge about your basic science. That is something which I want to insist here.
That's a great insight on history that we probably wouldn't have thought of. Thank you, sir. Riyaz sir, anything about the impactions of concern? Why do we need anatomy or any other related basic science knowledge for this?
Yes, 100%. Impaction is the bread and butter of all the young surgeons, budding surgeons. So I think normally whenever we have a call, a late night call, that sir, something went wrong in our routine extraction of mandibular third molars. So generally what the freshers, they tend to do is, they just mislead the vertical impaction and the distoangular impaction. See, the only difference between both will look alike, but the point of application will differ. If we are going to apply some mesial force for a distoangular impaction, 100% the tooth will not fracture, we will end up with the jaw fracture. Then you have to call the OMFS for plating that particular jaw fracture. So always both are looking very, very similar. So it is our bound duty as a young budding dental surgeons, you have to check whether it is a vertical impaction or a distoangular impaction, depending upon the difference of the space between the 6 and 7 and 7 and 8. If the interarticular bone is minimal, that means 100% it is going to be a distoangular impaction, and if it is more, it is going to be or equal, it is going to be a vertical impaction.
So essentially, sir, thorough knowledge of the anatomy would not only ensure that we are able to complete the procedure, but also prevent complications. Would you agree, Bhaskaran, sir?
Yes. I just want to make a point that this, as Dr. Karthik said, this lecture is all about the importance of basic sciences. So, looking at the case scenario, you first need to know where the facial nerve is, where the inferior alveolar nerve is, and what the relation is. And then, it just follows naturally that you will have devised a technique which will predominantly target the inferior alveolar nerve. And when can the facial nerve be injured? I don't think you can injure the facial nerve directly, simply because it's way far too behind. You cannot reach the facial nerve even if you want to with a needle. So what happens is with the angulation, you're entering the parotid space, and there the solution diffuses and anesthetizes the facial nerve. So for this, you must be very clear with your anatomy, how the facial nerve comes and exits, where it goes, and where the mandibular nerve comes out from the foramen ovale and enters the inferior alveolar nerve. So the point here is how important anatomy is, and how you appreciate anatomy in 3 dimensions would make all the difference in these patients. And then how you angulate the nerve is a natural following. How you angulate your syringe to target your nerve is a natural follow through. You will not, practically you will never injure the facial nerve. But you can get a facial palsy, temporary facial palsy, because your angulation is going towards the parotid. And then the solution enters the parotid and anesthetizes the facial nerve. So that's the importance of the anatomic, the applied anatomy of this particular procedure.
So we've covered some clinical situations that you guys are probably finding it easier to relate to because you regularly do minor oral surgery. But in terms of oral and maxillofacial surgery, sir, Karthik sir, would you be able to tell us how a thorough knowledge of the anatomy would help us even in procedures that are performed routinely, even by specialist surgeons?
That. Before that, before going into the hi-fi procedures of maxillofacial surgery, let us have a word about the basic dentistry. Ria sir was talking about some calls which he gets. I used to get some calls from my UG friends. They were practicing for more than 15 years. At times they used to call me and ask, Macha, ella okay. Ana the inferior alveolar nerve block mattu vela sey mattidhu. This is after 15 years. What is the problem here? They have not been proper in their basic anatomy, and to add on to the pharmacology of the LA technique, all those things. What they were practicing for 15 years is just a mechanical way of doing it. This might work for a few cases, may not work for a few cases. So the point here is to accustom with your anatomy and all other basic sciences in day-to-day practice matters.
Generally, sir, do you think that even in these cases where they tend to miss anesthetizing the nerve effectively, is it also got to do with the age changes that are not taken into consideration?
True. See, what is the technique of local anesthesia? The technique of local anesthesia takes few structures which you can see and target the area which you can't see. Your inspection is about things which you can see, and palpation is about things which you can feel. This is about the anatomy. Where your target area is something which you travel inside the body. If you can't imagine, or if you are not very particular about the anatomy, what you see and what you feel is the only thing which you know. But the target area is something very different.
Correct.
So again, coming back to the anatomy, which is very important, right from your day-to-day practice to all the complex procedures in maxillofacial surgery and dentistry.
So Bhaskaran sir, would you say that these are pretty routine procedures for a specialist surgeon, a TMJ ankylosis resection or a neck dissection for an onco surgeon? Why would we require an in-depth knowledge of the surgical anatomy in these cases?
Well, I don't think surgery can stand without anatomy. I think I always feel surgery stands on 2 pillars. One is anatomy and one is pathology. If you can't appreciate anatomy in depth, you can never be a good surgeon. I think if maxillofacial surgeon or aspiring dental students ever want to do maxillofacial surgery, you should be the best in head and neck anatomy. I cannot imagine any other specialty who can have better knowledge of head and neck surgery other than you. Other than maybe an ENT surgeon, not even a neurosurgeon, no other specialty should beat you. You should be the master of head and neck surgery. That's how important anatomy is for surgeons. Regional anatomy expertise is fundamental to good surgery. I think there's no 2 ways about it.
There is a simple quote which always says, your eyes doesn't see what your brain doesn't know. If your brain doesn't know your anatomy, you are not going to see anything in the operating field. Oh, as simple as that.
So take home, guys, your anatomy is fundamental and your eyes cannot see what your mind doesn't know. So because this is a maxillofacial conference, we're definitely going to drive home the point of anatomy being of prime importance, but we also have certain other basic sciences that are equally important, which you will hopefully understand why they are important in your daily practice.
Can I just interrupt and say, are there any first year students here?
Do we have any first BDS here?
No? Okay.
Oh, there are. So I
Oh,
think
there are
two of
quite a
them
few.
stood up.
Okay.
Yeah.
Okay. It's very important that you take your cadaveric dissection anatomy classes, extremely important. I just want to say a small anecdote that we used to do our anatomy I studied from Madras Medical College. It's a beautiful, huge anatomy hall with, standing on iron pillars from Sheffield, because this started, years and years ago under British rule. And the anatomy, we used to go in the night to actually get individual bones. Because when the fresh cadaver comes, do you know how even individual bones are obtained? You have to crack the skull. They use chenna, I remember. The technicians would pack the skull with chenna and pour water into it. So the chenna would bloat and crack open the skull along the suture lines. This is something that many people didn't even know, because you have to actually see it. And then when a fresh cadaver comes for embalming, you should go and watch it. It can only happen in a place like Ramachandra, because before they dip the body into formalin tanks and make it a cadaver, they will embalm the body. So you should go and see an embalming. They'll take out the femoral vein, the artery, they'll inject the dyes. You can see the fresh dead body sweat, and you know how they begin the embalming process. So your anatomy starts from here, and then you have to look at the whole process. Then you have to look at, you have to appreciate embryology to learn head and neck anatomy. So you should always wonder, and that's how you learn anatomy. And anatomy learning doesn't stop after first year. This is for the second years, third years, final years, and so on, and PGs. And, people like, all surgeons, including me, RITVI, everyone, you keep revisiting your anatomy, you keep revisiting your physiology, you brush up your pharmacology. So basic sciences is an ongoing learning process in life. Unlike many other, aspects of dentistry, because you do endodontics, you will forget everything else, ortho or, oral surgery or prosthetics. But basic sciences, you can never leave. It stays with you, it lingers on throughout your life. So, and I cannot, impress the importance of basic science in surgery, because as I told you earlier, surgery stands on anatomy and physiology and micro and everything else. So I would urge the first years to take up your anatomy classes very seriously, and even the second years, the third years, and the final years, to revisit anatomy. Go back to your cadaveric dissections. And I want to add, in a place like Ramachandra, you guys should learn whole body anatomy. Finish your head and neck in 6 months, and go on and do thorax and abdomen. Do the entire body. What stops you? You have the bodies, you have the cadavers. Your MBBS colleagues are doing the same thing in a year. You have the same year. So go ahead and at least do gross anatomy, because even nurses, even B.Pharm students would learn gross anatomy. So as an aspiring, dental surgeon, you should be aware of the complete human body anatomy, at least the gross level. It's very, very important.
I think that's a wonderful point you've made there, sir, especially when you have the facility to do so. Nothing should stop you from being more curious and actually studying the entire human anatomy. Riya sir, now we have situations in the clinics where our undergraduates are exposed to routine closed dental extractions, etc. How does physiology come into this? Is there any application at all for basic sciences? We teach them the mechanical principles of tooth extraction. We teach them how to compress the gauze onto the socket and give the post-operative instructions. But where does physiology come into this?
Yes, our physiology plays a vital role in our day-to-day practice. As such, what the particular coagulation factors and coagulation cascade, what we read in our guidance, it stands in our day-to-day practice. According to the American Society of Anesthesiologists, I think we can classify patients before any minor oral surgical procedures, and whether we have to stop this blood thinners. Nowadays in our OP, I think most probably we have patients on long-term blood thinners. So the rule of the school of thought has changed from our studies when we did that 2 to 3 days before the proposed minor oral surgical procedures, we have to stop those blood thinners with the consent of the consultant cardiologist. Then we have to proceed for extraction. Then after the extraction on the day and 2 days later, it was the protocol. But now everything has changed. Like Bhaskaran sir told, we have to be in pace with the current update. We cannot just like that think that we have studied anatomy, physiology, everything, it's finished. No. So when two doctors, in this particular point, I want to tell, when two doctors converse, and after finishing their evening patients, they tell how many patients you have not seen. They will tell how was your practice. So what does the word practice means? Practice means we learn from each and every individual patients. Even though we are there, I think Bhaskaran sir is there for more than 30 to 40 years in this field of expertise. But still, if sir sees a new patient, I think definitely he is going to start from all the basics. He will not leave even a simple thing to encounter. So I think if you know all these values, your normal, international normalized ratio, your PT, patient's INR, anything before the proposed procedure, and it is very mandatory today, the ethical concerns are so much. The court of law is so aware that it supports only the patients 100%. So we should actually have a protective code of knowing all these anatomical values and the physiological values, and we have to compulsorily subject all the patients, even though if it is going to be a simple minor oral surgical procedure, we have to ask them to do some basic blood investigations like your INR, BDCT compulsory, and make sure that it has been recorded in your case history before the start of the procedure. How important our concern is, like this, these blood values are important.
So the importance here, or the take home for you guys, is that essentially not only will it help you determine if the patient has an underlying bleeding or clotting disorder, it will also help you manage the patient in a situation where there is excessive bleeding post-extraction, right? So it is important not only to have the knowledge of these physiological parameters, but also be apprised with the updated guidelines as to how to manage them. Do you always need to stop the antiplatelets? Do the coagulants need to be bridged? These are the things that you need to take into consideration when you take up even a single tooth or a multiple tooth extraction. We'll move on now to the other specialty of microbiology. So we keep insisting upon sterilization protocols. We teach third-year undergraduates when they come into their clinics about how to glove up, how to maintain sterility on their tray. But how important is this? What would your advice be in terms of sterility, disinfection? Karthik sir?
Yeah. See, I don't think there is one single person in the crowd which says that basic science is not important. But at the same time, when I read few journals all over the world, the trend of students towards attitude and perception of basic sciences, I found some interesting facts. So, 20 questions were asked all over the world towards the students about their attitude towards basic sciences. One of the very important question is, do you feel you can be successful without a complete understanding of basic sciences? That was the question. Almost 50% of the students said, yes, I can be successful. That lies the problem. So if they think that they can be successful, they are not going to learn. And one of the difficulties what they felt is about the recall or remembering basic sciences when they start practicing it. So there is kind of two ways. There is some problem in the curriculum also. There is some problem in the attitude of students also. The idea is, whether you like it or not, your basic sciences is something which you are going to face in day-to-day life. For example, treating a space infection, you should know the anatomy to drain it. You should know the microbiology to know what exactly is the microorganism. You should know the pharmacology to give what kind of drugs. You should know the other biochemistry aspect of it to stabilize the patient. So whether you like it or not, this is something which you have to be accustomed to. Thank you.
So this would be a classical situation where you would literally integrate every specialty in your basic sciences in order to get the patient home.
True.
All right. Agreed, sir. But is pharmacology really that important, sir? So we write these prescriptions every other day. We have them writing prescriptions left, right, center for a simple tooth extraction, for an infection, etc. The standard group of drugs, we give broad spectrum antibiotics, beta-lactam, we give NSAIDs. But a patient who comes in has mentioned a history of an allergy. But we're giving the routine drugs which are considered to be comparatively safe. So why is this going to cause a problem? How do we apply our pharmacology knowledge from our second year into our daily prescriptions? How does it play a role? Bhaskar sir?
I don't think I like to answer this question because most of my pharmacology lectures were spent half asleep. I must be very honest. We have this lovely room in Madras Medical College, pharmacology block, second floor. Lovely curtains. The lectures are always at 2 o'clock in the afternoon, after lunch. And my pharmacology teacher had a very beautiful voice.
I think that's a similar situation in every college, sir.
And
afternoon sessions for pharmacology.
She was wonderful, and she would do this lovely lecture on alpha and beta receptors. And 10 minutes, I can assure you, will be very hard to stop snoring. So that was my pharmacology experience, undergraduates. So I will forgive you all saying we don't like pharmacology, or it's very boring, or the lectures are extremely sleep-inducing. But pharmacology, I think you learn much later. Pharmacology as a subject in undergrad is very, very dry. But there's a little book called SIMS. I don't know if you've seen it. It's about 200 rupees or something. All clinicians have it. All the drugs will be written there with the generics and even the brand names. It gets updated every month. Clinical students, I encourage you to buy one copy of SIMS and keep it with you. I assure you, you will not know half the drugs. Somebody will say clopidogrel or, telmisartan or whatever. There are a lot of new drugs, the new calcium channel blockers in the market for hypertension, new diuretics, lots of new drugs coming in. Even the anticoagulants, the warfarin is going out, new ones are coming in. Keep updating yourself with a little SIMS book. Ask your medical colleagues. That's how you learn pharmacology. But the fundamentals, extremely important. Learn the basics. Sir was talking about nerve conduction, the block not working. You should it's there in your Malamed, one full chapter. But see, it's all integrated, you see. You have to know about nerve conduction. You should know the resting membrane potential of every nerve. Why is your inferior nerve got a resting membrane potential of minus 70 millivolts? What does the resting membrane potential of SA node is? Ask these questions to yourself. And what does your lignocaine do? So pharmacology gets integrated with physiology. And that's when it becomes interesting. You read it standalone, it's extremely boring. I agree. But make sure you integrate your pharmacology and keep updating your pharmacology. That's the way you can learn pharmacology. That's my humble opinion.
Yes, sir. But also the fact that, sir, from an undergraduate perspective, when you write a standard prescription for every patient and there is a history of a drug reaction, so how important is it to look into the contents or the constituents of each, especially combination drugs are pretty common nowadays, and what is the importance? Can you end up in a situation like this? And if yes, then what do you do?
Yeah, there is a quote which says, your knife may not kill your patient, but your drugs do. So this is a big difference which every clinician should understand. So the drugs which you prescribe, you should know in and out about all the pharmacological compositions, its advantages, disadvantages, side effects, what is the drug dosage, frequency, all aspects of the drug. So there are two aspects. One, the drug which the dentist prescribed. Second, the drug which the patient already has it. So there is 10 drugs which the American Dental Association have given a list of, which has a big intervention between the drugs prescribed by the dentist and the patient, the common drugs which the patient already takes. How many of us have actual knowledge about all those drugs? No, it is not. So when everything goes right, there is no problem. But there can be a single drug which can make your practice go wrong, or your whole career can downhill from that one drug. So to be very frank, whatever goes inside, you should know right about all aspects of the drug.
So not just what we prescribe, sir, but also what the patient is already taking, because due consideration needs to be given to drug interactions is the point here.
Again, sorry to interrupt.
No
so
problem.
again, this is something which you're again going to treat with some other drug, right? Your
Correct.
drug allergy is again have to be treated with some other drug. So the whole aspect of pharmacology is going to save your life and your career.
Any guesses on what situation this could possibly be? I gave you a clinical scenario. Guys, anyone, what can this possibly be? A patient comes back to you after you've given them a prescription with these symptoms. There's some swelling around the lips in the image above, and there are some rashes below. Ma'am, this was only meant for the participants, not the faculty. Any participants want to tell me what that possibly could be? Anyone? No guesses? Sorry? I'll
Give a
make
mic
arrangements.
to someone. Guys, open up. It's okay to make mistakes. We do it all the time.
So this is the next clue. It could lead to that. Now what is it? The symptoms could start with this and lead to that. Any one person? Anaphylaxis. Okay.
Good.
So that is what Sir was trying to explain to all of you, that it's not only what the patient, what you are prescribing to the patient, it's also what the patient could already be on, and so the consideration to be given to drug interactions to prevent medical emergencies. Riya sir, would you like to add on what should be the ideal course of management in such situations? What should they be equipped with in a dental office?
So 100% first, before giving any drugs, parenterally, patients 100% we have to have the crash cart with our practice, day-to-day practice. If crash cart is there, 100% we will be saving the patient's life before you activate the ER or activate the emergency system. So this crash cart has the basic vital drugs as well as the O2 and the all the vital monitors are there, so that we should activate the ER on the other side as well as we have to give the life-saving drugs to save the patients as soon as possible.
So the summary of the pharmacology session is that boring, dry to study, but extremely important in your clinical practice. We then have clinical situations, sir, where we have vague x-rays. We get patients with not very clear symptoms, but they seem to have a long-standing history, sometimes not very long, acute symptoms. How do we go about things like this? How does our pathology knowledge help us in diagnosing these patients? Karthik, sir?
So again, one of the interesting facts which the students have all over the world is about their recall regarding pathology. When they were asked about how do you relate your basic sciences to the clinical practice, the first one they say is they remember pathology well. Because in day-to-day scenario, they encounter few problems which they relate to their basic science. Again, regarding the pathology, unless and until you know all aspects of the disease, whether it is an abscess, or is it a granuloma, or is it related to the bone, unless and until you know all aspects of it, you may not be able to give a differential diagnosis. If you don't have a differential diagnosis, you will never know what investigations you have to do to come or arrive at the final diagnosis. If you are not going to arrive at a final diagnosis, definitely you can't treat it. So it is not only about the day-to-day scenarios, it is about the wholesome pathology of your problem. So that is something which everybody has to know about.
Correct. I think the participants of yesterday's Face the Case would be able to relate to this, wherein you were given a clinical scenario, you had a chief complaint, and then you had to take it forward with your history taking and your differential diagnosis, right? So the reason you scored points for that is because it's the thought process that counted, right? And without a basic knowledge of the anatomy, so the scenario here is a case of an osteomyelitis in the mandible. So unless you have knowledge of the anatomy of the mandible, knowledge about the blood supply, knowledge that this is more likely to occur in that particular jaw because of this anatomic variation, is only then you can put the pieces together and probably come up with your differential diagnosis. So your pathology, again, like anatomy, remains key to be able to come to a diagnosis. Bhaskar sir, this is a topic of your interest. So we covered a lot of topics in basic sciences, but how do we put them all together? What does it essentially correlate to? Can you tell us a little bit more about that, sir?
Okay. Okay, you want me to talk on the slide or on general guidelines? I think if I have to say, on general guidelines, any patient you see, particularly this is for clinical students, irrespective of what the patient comes to you with, the appearance, be a swelling or a fractured facial bone, you start from your absolute basics. Take a clean history. I would do history taking for you in one slide, and the entire history taking, I would condense it in like 1 minute. All you have to do is ask the patient the complaint in the patient's own words and the duration. That's your entire history in a nutshell. This is what I've been doing for the last 20 years in clinical practice. Do not manipulate the history, particularly the complaint. The chief complaint, it's patient's own words. Not a single word you modify and say. Don't get technical with it. Don't say patient's got pain in the angle of the jaw, angle of the mandible, or pain in the intercanthal region. Nothing of that sort. Simple English or simple Tamil, whatever the patient says, that's your chief complaint. And the duration, extremely important. A swelling for the past 2 days, the same swelling for the past 20 days, or swelling coming and going in the same region for the past 2 months. Totally different ball game. Okay, so duration, important. That's it. Your history is done. Then medical history asks only 3 questions. Any history of major illness in the past. Then you classify that according to your convenience. You go down CVS, RS, CNS ladder, or whichever way you like it, or you name the diseases. But it's one question. Any major illness? Any history of hospitalization in the past 5 years or 10 years? And then history of medication, history of allergy. Actually 4 questions. And that's it, your entire history is done. If we can do this consistently for every patient, you can ignore the rest you find in a medical textbook, a clinical medicine textbook. This is all the history you can ever need. The trick is not in an exhaustive history. The trick is in being comprehensive and consistent. You will ask every patient for the rest of your life the same questions, because this is the absolute minimum. If you can do this, your history is done. I ask one more history. I always ask personal history, because that's when you develop rapport to your patient. Your patient builds, bridges with you when you start taking personal history. You will learn that slowly, don't worry. That will come to you with clinical experience. And some humility. That will come later. But do this. This is the absolute minimum. And general examination, again, I spend about 2 minutes. I can get it down to 1 minute for you guys. Look at the patient top to toe. From the vertex of the skull to the toe. 5 seconds. Do this. Don't jump into the mouth and look at teeth. 5 seconds you spend looking at the patient from top to toe. This is a general exam. Another 5 seconds, look at the basic signs. I call it the day of the jackal, to remember. Jaundice, anemia, together you can look at the sclera and the palpebral conjunctiva. It's done in 5 seconds, 2 seconds. Ask the patient to look up and look at the palpebral conjunctiva. Ask the patient to look down and look at the bulbar sclera. That's it. You ruled out jaundice, you ruled anemia. Then clubbing and cyanosis. I don't have to tell you. Look at the nails, look at the tongue. Ignore peripheral cyanosis. Just look at the tongue. If it's bluish, that's cyanosis for you. Central cyanosis is the only thing we need to worry about. Don't bother about peripheral cyanosis. So you've done JACC. Look at lymph nodes in the neck. If you're good, look at the axilla. Then look at edema. And only thing, either full edema, anasaka, or look at the pedal edema. Pitting pedal edema, always suggestive of congestive cardiac failure. If you can just do this, this will take another 10 seconds. And you are almost done with your general exam. Then, being the regional expert, look at the mouth and go into the neck one more time. Though you've done the regional notes, do it again correlating with the clinical condition in the mouth. After this, only you look at teeth. This is nothing to do with oral surgery. This is for every dental surgeon, every healthcare worker, every ENT surgeon who look into the mouth or that particular region, into the nose, into the ears, into the eyes for opthal. It's the same. You do this, you become a good clinician. It does not matter whether you're a dental surgeon or an ophthalmic surgeon or an ENT or a maxillofacial. This is fundamental. Follow this religiously. Ask your well-qualified nurse to do a pulse and a BP checkup in the same time. If you are very dedicated, you will do the pulse yourself. That's what I would recommend as students. Just check the pulse and do it for that 1 full minute. Don't cheat like we used to do. We'll do it for 10 seconds and multiply by 6 and say pulse rate is 630, 70 per minute. Do it for 1 full minute. At least half a minute, multiply by 2. That amount of cheating is allowed. But you'll be surprised how much you can pick up. Simple, you can pick up atrial fibrillation in your clinic just by looking at the pulse. Simple, straightforward, irregular pulse. That's atrial fib for you. It's easier than diagnosing pulpitis. But these are fundamentals. You must do it. Always check blood pressure. You can pick up early renal failure just by picking up a high systole for a young patient. So these are absolute fundamentals. If you do this, all this becomes easy. Like they say, take care of the simple things, the big things take care of themselves. It's so true in medicine. So just do a good history, do a good clinical exam. Everything else comes later. All your CTs, your latest investigations, your PET CT scans, your MRs, are no comparison to a good clinical examination for 2 minutes. So that, I hope, answers your question.
Perfect, sir. That summed up their third year of study. That's the reason you have a light year in third year, I guess, because you have a lot to read and a lot to sum up. So that was the general surgery and general medical aspects. But now that we've covered most of the applications of all of our basic sciences subjects, we would love to hear about each of your experiences in your early years, your later years, about what could be the potential problems that you faced in your clinical practice when any one of these subjects were ignored or overlooked, I would say. So have you had any experience? I'd like to hear from all of you, sir. Riya, sir, we can start with you.
Yeah, to start with the routine dental implant practice, I do dental implants for the past so many years, from which our HOD Ravindran sir has taught us when I was an old student here. So from that particular time, we know that the sterilization is important. We have to sterilize the instruments before placing before doing any procedure, all those things. But how important is that whenever we are going to place any dental implant, is that to sterilize or fumigate the room or fumigate the dental chamber, the whole entire lot. So that also plays a very vital role in the success of the dental implants. Moreover, whenever any surgeon who practices or any doctor who places nearly 1,000 implants, he or she will think that, yes, I know A to Z about implantology, what is there. But always it is a basic rule that you do, like Bhaskar sir told, you do the ABCs. You make sure that you record all those things. You take the CBCT of that particular region alone, so to just check the third dimension. So now I think all the dental surgeons who are there or the maxillofacial surgeons will accept that. What about the mental nerve loop? Whenever we are going to place any dental implant in that particular region, we have to take the CBCT and find out what is the distance between the interdental implant as well as from the loop and above, how far we are going to stop apically. So whatever technology is there, I can do it. Dental implants, I think in China they have done a robotic dental implant placement. So ultimately the robotic arm, it does only the implant drilling sequence, nothing else. The flap is reflected by the surgeon, the wound closure is done by the surgeon, only the drilling sequence is done by the robotic arm. So ultimately what does is, the basics of any implant or any procedure is, we have to follow all the norms accordingly and record all the details about the patients pre-operatively, intraoperatively and post-operatively to have a good practice.
Thank you, sir. Karthik sir, have you had a situation where there's been an unexplained bleeding, hematoma?
I'll tell you a cutie story about a case which I encountered, which I could not able to diagnose. So there is, if you can diagnose this case, let me hear it out. So there is a man of almost 40-year-old, came with the swelling of 7x7 size, painless, firm in the right maxillary region. with all those investigations, clinical, radiological, it was not an dental infection, it was not a cyst, it was not a tumor, it was not a vascular lesion. Right in the right maxillary region. On CT, there is some breach in the maxillary sinus. It was foam, it was of 7 centimeter, painless. Any guesses from the audience? Or do you want any more information?
That's very unfair.
Other people can also make a guess.
Sneha ma'am, you're allowed to answer this one.
Come again, Sneha? No. Please. No history of antibiotics. No. No implant, no dental history. How many days?
You are a mic.
3 months old, slowly growing. Not a tumor, not a cyst, not an infection, not a vascular lesion, nothing else. Yeah, இதே மாதிரி தான் நானும் ரொம்ப சைலண்ட்டாக இருந்தேன். ரொம்ப எனக்கே தெரியல இது என்ன எப்படி ட்ரீட் பண்ணுறது அப்படின்னு சொல்லி. ஸோ ஐ வெண்ட் பேக் டு மை பேசிக்ஸ் விச் இஸ் history taking. The one aspect I missed in the history taking is his occupation. He was breeding pigeons. A very important aspect of the whole scenario here and the point of this presentation, history taking. And he was breeding pigeons. When I started reading about pigeons and occupation, all those things, I came across the term called breeder's lung, which is basically aspergillosis, as a fungal infection. If only I had an idea about infections, that too with a fungal, I would have diagnosed earlier. Again, this one is diagnosed as aspergilloma, not even aspergillosis. It was a fungus ball, which can be treated purely by antifungal drugs, which we did. So the importance of this Kuti story is, again, go back to your basics, your clinical history, your microbiology, pharmacology, everything else is important if you come across a patient which is not the usual one. Thank you.
Thank you, sir. Bhaskar sir, one quick anecdote from you before we move on.
No, nothing. I just want to confess that I learnt my implant only from my students. I have no clue. And I won't do implants unless my patient forces me to do nowadays. But yeah, it just drives home the point I said earlier on. Take a good history. See, that proves the point that you have to take personal history as well. It is occupation. I go down, I tell my students, know about your patient. Apart from everything, find out what he is doing, what he eats in the morning, does he smoke? Does he, go and enjoy a weekend drink? Does he have a girlfriend? What does he do? What's in everything? That actually goes a long way in diagnosing, stuff like this. That's the exotic stuff. You don't get aspergillomas every other day. But history helps you crack those problems. Not the high-tech investigations, it's the history sometimes.
So treating the patient, not the condition.
Yeah, absolutely.
So Karthik sir earlier mentioned about perception of students towards basic sciences. So we've had studies to back this, and there have been studies that have been done between dental students, medical students, and practitioners, and they found that at the end of their study, when they actually get into clinical practice, students have found that their anatomy knowledge and their basic science knowledge is not sufficient to help them in their clinical practice. And the same opinion was shared by established practitioners and surgeons who felt that the students that they taught did not get adequate hours of teaching. So again, like you said, Karthik sir, it's part the attitude and part also the curriculum, which hopefully someday will improve.
That is true. This hall exactly replicates the attitude of students and the clinicians. If you can able to see, the senior people are in the front row, the last benches were occupied by students. There's a big gap in between. So
The
this gap
clinicians
has
are
to be
paying rapt
bridged.
attention and the
This gap
students not
somehow
so
has to be
much.
bridged.
So the hint was for the students to occupy the front row from here on, at least the next panel. So we'll move on, sir, to how do we learn better? So what's the solution? Are books replaceable? Do we go back to our books and our labs that are readily available at all of our universities? What's the solution, Bhaskaran, sir?
I'm a bit fussy about books. At the risk of blowing my trumpet, I would say I read 5 books for anatomy in my first year. I read part of Grace. My fundamental book was Snell's Clinical Anatomy, and a little bit of R.J. Last, and then of course Chaurasia for exams, and Cunningham. But I think the point here is not to read too many books or the best books. Read a good book. I have no bias towards a foreign author, but some of these books are time tested and they make you fall in love with your basic sciences. I think if you read R.J. Last, you'll start loving anatomy. Okay? Chaurash will make you score better in your exams. It's a lovely book, no doubt. But you need to read an anatomist book written by a wonderful anatomist who's enjoyed anatomy. And a last book is one such, masterpiece. So try and read R.J. Last. I was examined, my fellowship exam, I was examined by an examiner who was R.J. Last's direct student. So, embryology, read Craniofacial Embryology by Sperber. And physiology, definitely Guyton for undergrads. If you've done Guyton once, you can read Ganong, but Guyton, there is no alternative. You will just fall in love with physiology. So, pharmacology, I did the same mistake of reading Satoskar only, because I couldn't read Goodman and Gilman, and I hated pharmacology in my undergrad. Microbiology, the Indian book is good, that Panikkar and Ananthanarayana. It's a very good book. You can read alternate books, but the point here is books are the go-to things. I know you guys have all chat GPTs and your Googles and your YouTube softwares, Marrows and Cerebellum, but I think go to a book still and read a chapter. Read the absolute first chapters, the first line of every book and the first chapter. You will know. You will know where you stand with that. Some books will give you that vibe. Take up that book, buy it even, and keep reading it. That's my very, very strong recommendation. Books really make the difference, and they make you wonder. I think you need to wonder why this is in anatomy. It's very simple. Your face is trigeminal nerve. We all know trigeminal nerve is the sensory nerve of the face. You must wonder why this is ophthalmic, maxillary, and mandible. Why this part alone is a cervical nerve? Now, why is C2, C3 supplying the cheek? Now, the books make you wonder, and they give you the answers. That's how you read anatomy. You need to wonder. You need to know why. Why mandibular nerve supplies one little muscle in the ear, tensor tympani, and the muscle next to it, stapedi, is supplied by a facial nerve. It's so stupid. How can nature be that stupid? 2 cranial nerves for 2 little muscles in the ear? Crazy, isn't it? But why? You need to wonder. Why the tongue? It's got hypoglossal nerve coming all the way from the back. Just 1 cranial nerve for all the muscles of the tongue. And then 1 muscle of the tongue alone supplied by something else, the palatoglossus. So all these things you need to wonder. And that's how you learn anatomy. And these books give you the answer. They make you fall in love with these subjects. And that's how you learn your basic sciences. Basic sciences always give you a lot of creativity. Remember that. Your clinical sciences don't give you creativity. Remember this. Basic sciences give you creativity. Your mind opens up. You become very creative. You become utterly confident. All that comes with the basic sciences only.
So books are irreplaceable, sir. And you've also spoken about the importance of doing a lot of cadaveric dissections, not just head and neck anatomy, but also the general full body anatomy. So, of course, studies support your claims that the cadaveric dissections do help in getting a better orientation to clinical and 3-dimensional anatomy. And that is probably, it's like you said, it's better tried on cadavers than on real patients. So, Beyond that, sir, Riyaz sir, now with the advances in technology, we have books, we still have cadavers, and we can get a lot of information from them. But how best can we use technology to help us with our reading? How can that help us orient basic sciences and make it more interesting for us?
See, the commonest example will be you want to fly a aeroplane or anything, 100% we have to spend so many hours in the virtual room or virtual reality, so that you first pass that, then only you can take up the smallest ATRs, or then you can fly. Don't compare that Air India, I'm just telling about the normal thing. So in virtual reality, 100% before doing anything, as Bhaskaran sir also told, we can go into this particular e-learning tools. It is so very wonderfully that I can be myself as the nerve, or I can buy the dissection tool where I can dissect inside and then just go apart all along the nerves or vessels and muscles, so that I can learn each and every part of that head and neck curriculum in three-dimensional way. Not only the normal textbooks or not only the routine pages. So I think definitely this VR, and I think SRMC is one of the pioneer institute which is blessed with the virtual tool reality. All the students are very blessed by their parents to admit them here. So virtual reality plays a very vital role in before doing any proposed surgery. I think in the maxillofacial surgery it has come into real life before we do any OGS or any planning, any microvascular surgeries. I think virtual reality plays a day in, day out as a tool.
Right, so in fact, our participants had a good opportunity yesterday in our VR lab to actually get a feel of how well they can study the anatomy and actually move things around and see how they can learn it better and do better procedures. So we've moved on to machines, we've moved on to technology, but is that it? Does the machine determine what you do, what you operate, what you perform, or do basic sciences still, are they still the foundation?
Yes, 100%. I think all the audience and the staffs here are very familiar about this Da Vinci system of operating. See, even though there are so many laparoscopic arms there, nearly some 8 to 10 arms are there for doing a laparoscopic surgery, but still the boss is only the surgeon who knows the in-depth anatomy of all the parts. And he knows he is the mastermind. He controls the joysticks so that each and every precise incision to suturing or from operating that particular area, he knows how to control each and every robotic arms. So how, even though so many machines, AI, all those things are there, how well we are equipped with the basic sciences are much more important than the consoles or compared to the armamentarium.
So again, the point to take home, guys, is that even with advancements in technology, even with all the fancy tools, you still need to have the basic knowledge. You need to have the knowledge to be able to apply and use these tools. So what use is the equipment without getting equipped? I'll leave the take home for all three of our panelists for their own interpretations. Riya sir, would you like to start?
I would like to start with this. I like this particular center picture diagram. So if you are going to start up with the basic sciences, starting from point number 1 or score number 1, and you climb the ladder like your basic anatomy, physiology, all those things you make up, and then you come back to 100, you are going to do any maxillofacial surgery or you are going to do any part of dentistry, 100% you will not have any problem to come down. But by using any shortcut methods like your AI and all the other tools, you want to basically relying on the tools and the technology, but without knowing the basics. Sometimes I'm very sorry to tell that at the point number 99 or the score number 99, you have a very big danger or very big complication which can draw back to your part 1 or stage 1.
So AI here, sir, as sir said, is figuratively the snake at 99. So you wouldn't want to get there and have a free fall unless you have your basic knowledge. Karthik sir?
To conclude, there are two aspects of it. One is the attitude of the student regarding basic science. Number 2, the teaching modality of the staff member towards basic science. So these have to come together in order to make a better tomorrow. Thank you.
Bhaskaran sir, closing statements.
And no, I just want to say you guys are so lucky now. With all these tools you have, with the AI, with YouTube. I mean, we used to have this one skull and a bendy wire. And, for me to reckon the carotid canal's route, through the foramen lacerum, look at the pterygium maxillae fissure, it'll take me weeks to understand. To imagine the retropharyngeal space would, take me weeks again. Now you got it all figured out. You got softwares which will walk you through every human anatomy, every bit of space. You got all the tools in your hand. So I think it is all laid out for you. All you have to do is just develop that passion. It's very important that you do it. So basic sciences you read a lot, and you read it again and again. Repetition is the way forward. I think repetition is the only way you can learn basic sciences. You learn anatomy once, you will forget it. But as somebody said, it's better to read anatomy and forget it than not have read it at all. Pathology you learn with your teachers. You can't learn, sir was showing you a case. And if you had shown me that case, I wouldn't have answered the question as per Giloma. So pathology you learn only with your teachers. That's the wealth you have. So you got the best of both worlds. You got, great technology at your fingertips, and you got these experienced guys who are waiting to handhold you and take you through all this. So I think you are a very lucky generation. Make the most of it. But basic sciences, you got to give it a lot of passion, because it's like swimming. Once you've learned it, they can throw you in a pool or in 100 feet well. It doesn't matter. You're going to come on top. So learn that religiously, and then get all you can from your teachers. Catch your teachers, torture them. It should not be the other way around. Teachers should not torture you. You should be torturing them. Don't confuse obedience with discipline. That's the other thing I want to say. Don't rush to get up when your teacher crosses you. That doesn't matter. You can sit back and put your feet up. But you must have the discipline to run to the teacher. Come to class 5 minutes earlier. Take everything that your teacher throws at you, absorb it. And then if you can't, go back and nag him. And that's the best way to learn. And if you can do this, I think you guys are going to be teaching us many things in the future. Because you guys are the hope, you guys are the future. Thank you.
Thank you, sir. Thank you to all of you. Thank you to the wonderful panelists for an excellent session. Thank you to the audience. I'd like to also thank the association and the team at Ramachandra for giving us this opportunity. I think it was a great session, and we hope that it was beneficial to you. Basics are fundamentals. Thank you.
A hearty thanks to our esteemed panelists for this insightful discourse on the importance of basic sciences. Your perspectives have not only reinforced their foundational role in clinical excellence, but also reawakened our appreciation for the why behind the what we practice. I now call upon Professor Dr. Emmanuel Azaria, Department of Oral Maxillofacial Surgery, Sri Ramachandra Dental College, to felicitate Dr. R. Riaz, Head of the Department of OMFS, Tagore Dental College. Dr. R. Karthik, Dr. R. Karthik, Senior Consultant, Oral Maxillofacial Surgeon, Private Practitioner, Chennai. Dr. M. Bhaskaran, Consultant and Director, GEM, Head and Neck Hospital, Tirunelveli, Faculty and Examiner, the Royal College of Surgeons of Edinburgh. Dr. RITVI K. Bagadia for moderating the session so beautifully, Senior Lecturer, Department of OMFS, Sri Ramachandra Dental College.